cool about the ribs, right? Let's just get rid of this stuff. Basically, I showed you where the top of the rib was there. I was like, okay, this is 1, this is 2, this is 3, this is where you're at. Basically, the ribs 1 through 5 or 6, depending on, the anatomy, 2, 3, 4. We're saying 3 is usually the injured one for you. And we have, I guess you can say 1 through 7 technically are the true ribs. AKA, true ribs are ribs that actually attach to the sternum.
Okay.
Then they have false ribs. False ribs are essentially these bad boys that attach, but not directly to the sternum. So basically, the 8, 9, and 10 come down and they attach to 7 that create 1. So they're false. They're not. They are real, but. And then of course you have the floating ribs that are 11 and 12 down here that are just kind of hanging around here, protecting organs a little bit. They do not attach to anything. But the rib over here essentially is bone, like right on here. I know it's kind of hard to say it, but like it's pretty much bone here. Oop, right there. It's bone there, but then it starts to become more of a cartilaginous piece, like right around here.
Okay.
And where you're pointing to basically the interface between the transition point of the cartilage and the bone. By the way, that's where a lot of them get pissed off.
Okay.
So if you ever popped cartilage, you probably don't see this in your sport, but if you ever popped a cartilage where people talk about it like, oh, I feel it right here, or if you've laid on your belly for too long and you feel like a little irritation, most people don't feel like the irritation like right there, or here. They feel like slightly around here. That's where the transition period, and so the cartilaginous disruption can start to occur.
Okay.
So I think that's what kind of is happening, not in a bad way. Like one of the ways you treat that, is essentially by treating the musculature around it, the pec major, because like the pec major does do the adduction of that. That's where you're like, oh, that makes sense. And then of course it has its fibers that are kind of oriented like right around there, around the chest wall, but they also attach. Let's get rid of this guy. They attach right to here and to the wall, so that you can see how these cause some irritation. Sometimes also the pec minor can cause some issues, so we usually work some of the pec minor, and also of course the intercostal, aka the muscles in between each rib.
Okay. Yeah.
So that's kind of how I do that. Usually adjusting these things, in my opinion, this is just my opinion, just from doing it a shit ton of times. I don't like to adjust them. The reason I don't like to adjust them is because they are cartilaginous. There is disruption. Essentially, there'd be like this interface, and I say interface in a weird way, where it's like a transition period. Like imagine if this rug was transitioning from, I guess you can say, a good rug to a bad rug. We wouldn't really be as, we would be careful on that bad rug. We don't want to cause more sprain or strain.
Right.
And in these types of cases, like if you think about the ribs are such a unique set of types of injuries, is that if you like had a tendonitis in your calf or your Achilles and you're like, it hurts, I ran too much this week, you'd be like, I can kind of do some upper body, I can do some other stuff, I can, still train pretty hard, I could do the assault bike upper body.
Right.
You could do stuff. Well, if you do that, you increase your heart rate, respiration, and then in this case, like anytime you breathe, you're causing slight irritation to it.
Yeah. So have I been making it worse from running, even though I'm not like breathing heavy and stuff?
I don't know if you're making it much better.
Okay.
But I don't know if you're making it much worse. I think if I had to grade 1, 2, or 3, I'm grading it a 1, aka the lowest level.
Okay.
I don't think it's anything seriously like that. But also when I pressed on that T3 spine, and again, the ribs are unique because they also have this like massive angulation. You'd be like, whoa, where would T3 be? You'd be up here. You're high up in the back, but like look at how they have this like orientation where they kind of like dip down. They kind of like have this weird angle. So the T3 rib is like here, but it's like, oh, the T3 vertebra is like all the way up here.
Yeah.
So it's like significantly different. So when I stabilize that rib back here, it prevents what I did is I just pushed my thumb in there and held it.
Yeah.
You're like oh, I can actually breathe a little bit easier.
Uh-huh.
So I think if we adjust you, we can create some movement there that will help the rib around. And think about it, it's called a rib cage for a reason. It's fixated at all areas. So if you adjust one area, you're technically adjusting the whole circumference of it.
Yeah.
It'd be like tearing a little bit of a cage, like a bird cage, and like just ripping one of the line. Oh, you kind of displace some of the integrity of the entire cage. Right. So also in this case, I actually provided some stability, and we can cause an adjustment up there as well, which is fine. I think we created some stability there, and that actually fixated this and actually allowed it to not expand as much. So what I'm saying is you're having a little bit too much movement in there, probably from a sprain, and now it's causing some irritation.
Yeah.
I think what we can do is we can practice other things like diaphragmatic breathing as an option, like, you know, breathing from the here, which is what you did, and you're like, hey, I don't really feel it here.
Right.
So chest breathing.
So belly breathing.
Belly breathing as a transition, as a way of restoring range of motion, and as a way of like tightening up the core, but yet still getting some other stuff. And then controlling your breathing. If you do, you know, let's just say you're going out for, I don't know, a workout in here today, and we say, hey, go into there. Let's focus on like, oh shoot, all right, I know I'm breathing a little harder. You literally have to take the step back in your mind, breathing a little harder, transition it to the chest, transition it a little lower. Okay, now it's here, get it a little lower. Okay, so now you were doing, let's just say, a leg workout, and you're starting to increase your repetitions, and you're starting to breathe a little bit more. Let's take a step back, maybe do a little bit more recovery. Instead of it being as much of an aerobic workout, it becomes maybe slightly more oxidative or anaerobic.
Gotcha.
So it's a way of saying active without causing irritation in that area. So this is kind of what I'm thinking is happening, is that you kind of just have a little irritation to the costal cartilage here. Right here, it's nothing within here at the notch of it, where it notches in. That's where you kind of get a little, hey, can this get displaced? To answer some of your question about what maybe your massage therapist is like, hey, maybe it's a quick adjustment, you could just pop it back in. It doesn't necessarily work like that.
Okay.
If it, quote, popped out in this case and then popped back in, it would be in. It just there's just some irritation, right? It would be like me dislocating my finger and it going back in.
Yeah.
It would just be back in, but it'd be pretty sore the next day. If it is out, it's essentially a dislocation where we're kind of causing other issues. But like when I do adjustments, I'm talking about more differently, like alignments.
Okay.
Like actually making sure there's optimal alignment, that things are aligned properly, and if we need to mobilize things without you having to cause more irritation, I'm totally down with that. If you do, no offense to me or any other chiropractor, but if you do want to go see another chiropractor or myself, I'm going to adjust you face up. Usually face down compression on this makes it worse.
Okay.
So we will not be adjusting you face down.
Okay.
Just to give you some early warning. So you'd be like, well, why is he adjusting me face up? It's because when I push on your rib cage from the front part, you're like, ow, that hurts. So what do you think is going to happen is if I have you face down on a harder surface and then I jump my weight onto your back, you're going to have all that weight start on the back, and it's going to transition around the front because energy is not created nor destroyed. It's just transferred, and it's going to transfer into the front of the irritated rib. And it's going to go to the path of least resistance, a.k.a. right where it's injured.
Oh, yeah.
And the reason we have cartilage in our ribs, by the way, is to allow that pliability so that we can get that expansion and contraction. It can't be just a fixated cage, otherwise we'd have no mobility.
Right.
So that's actually the reason for the cartilage primarily in the front of our ribs.
Makes sense.
And especially because we don't breathe like this.
Yes.
We breathe here.
Right.
So that's actually the reason why we have rib cartilage in the front.
Amazing.